first liquid biopsy recognition samples, and it's perhaps the oldest laboratory test in the history of mankind. Interestingly, even the old inscriptions around 4000 BC have recorded assessment of urine on clay. So it is one of the oldest laboratory tests actually. And even on our Indian texts, the Sanskrit medical works, they also actually describe 20 different types of urine. So it was a pretty exhaustive. So a lot of work on urine had already been done before the advent of modern medicine. So I'm sure all of you must be aware of this. Urine analysis is basically involves three major components, if you want to divide it that way. First part is the physical examination, where you see the volume, color, odor, reaction, and all those. The second part is the biochemical examination, which we will be taking up today, which includes evaluation of many biochemical elements in the urine sediment and the supernatant. And the third part, which we'll be focusing on today, is the microscopic examination. So just to give a brief outline at the beginning, so we will be covering the cells, the crystals, the casts, the various microorganisms which can occur in the urine sediment. So the first step is centrifuging it, and it's very important to know that you need to centrifuge the urine only at around 1500 to 2000. So you should not use it less than that, and you should not use more than this RPM, otherwise it will either not give you enough cellular elements, or if you centrifuge it at too high a speed, your cellular elements may get degraded and you won't be seeing the cells as they should appear in the urine. Can make a misdiagnosis. And then you obviously examine it under the microscope. You just place a cover slide over it and examine it fresh. So the ideal way to examine the urine sediment is to view it fresh, and most of the times you don't even need to stain anything. So what you can just do is, once you put the slide and the cover slip, the slide with cover slip under the microscope, just lower the condenser of your microscope to maximum possible. So what it does is it creates kind of a contrast between the urinary constituents, and with practice you will be able to identify the various constituents of urine even without performing any specific staining techniques. So it's just a matter of practice, and you can easily do a good urine examination. Having said that, there are several stains which you can either make in your laboratory, or even commercially available stains which can highlight the specific cellular elements. And then when you have specific clinical questions in mind, you can specifically stain those sediments. For example, if you want to look at eosinophils, so you have a special stain by which you can stain eosinophils in the sediment itself and diagnose them. And if you have an advanced microscope, or you have a facility for a polarizer or a phase contrast microscope, this contrast which I have told you earlier by the first step can be further enhanced. And if you will notice in this lecture, many of these images, including the one on the right side you can see here, is actually a phase contrast image, this one. So it does give a lot of contrast to the images, so it helps you to identify the various cellular elements in great detail. And now before you start examining, there are certain prerequisites which everyone should know. And as I've told you, the urine should be examined as rapidly as possible. So as soon after collection, you should be able to examine the urine, and the ideal time is within 30 minutes. So there are a lot of variations in the various summer and winter seasons, if you have those seasons in your area. But 30 minutes is an ideal time to examine. But if that is not possible, of course, that's not possible many times. So you can refrigerate the urine immediately, but do not store it for more than 6 to 12 hours after collection. This I'm talking particularly in terms of doing a microscopic examination. And once you are ready to do the urine examination after taking the vial or the container out of the refrigerator, you should ensure that you bring it to room temperature. You should thaw it. So don't immediately, after taking the vial out, you should not immediately put it on the microscope, because you will see a lot of artifacts. So just thaw it, get it to room temperature, resuspend it, and then only bring the slides for analysis. And it should never be frozen if you want to do a sediment analysis. So the frozen urine is not advisable to do a microscopic examination. And whenever you are beginning to do your examination, just before you make the slide, you should always note the volume of sediment. So for example, if you have a sediment which is 0.2 ml, it will tell you beforehand that you have abundant cellular elements already in that sediment. So you should always make it a point to note down the volume of sediment before you start the preparation of the slide. So as I just told you, staining is not required most of the time, and just by lowering your condenser, it will give sufficient contrast. Having said that, as I told, there are several stains available, and the choice of these stains will be dependent on the clinical question. So if there is a particular clinical exam, for example, if there is a post-cardiac surgery patient, and the patient, you know, because of instrumentation, sometimes the atheroemboli can dislodge. So in post-operative period, you often do a urine for eosinophil. So that's a very specific question. You can just go ahead and stain the urine sediment for eosinophils and give a direct, very clear-cut answer to the clinician regarding how to manage the patient, right? So what we'll do is quickly in the next few slides, I'll quickly let you know the various stains which are available. You need not have all the battery of stains in your urine laboratory, but depending on where you are practicing and what is your clinical situation, you can keep a few of them and just refine your practice. That is the main aim of doing a sediment staining. So as you know, there are many times you get epithelial cells which can confuse your diagnosis, and it's difficult to distinguish the epithelial cells from the other cellular elements. For this, you can actually do two types of stain to stain these cells. So one is called the S staining or the Sternheimer staining, which uses Alcian blue and pyronine B. The second, so-called SM staining, is there's a modification by Malvin of the original Sternheimer stain. This uses crystal violet and saffron blue. So these are, and what you can do by these stains is you can get a shade of colors in the various epithelial cells, and of course in few cellular elements also, but it does give a very good viewing of the epithelial elements in the microscopic setting. And this is what I was telling you. So even if you don't stain it and you lower your condenser, this is an RBC cast. So even this is just by lowering your condenser and adjusting your light, you can actually see the details of the various cellular elements in great detail. Now there are conditions where you will need to find out if there is any fat in the urine sediments. So if there are clinical conditions like nephrotic syndrome or where you suspect fat in urine, you may want to see the fat in a better manner. So for that you can do a Sudan 3 staining. So what it does is it stains the fat globules, the fatty casts and the various oval fat. I'll show you these in later slides, and it stains them slightly yellowish red. So you can identify it up front. Now sometimes what happens, you also need to identify, or not only identify, differentiate the granulocytes in the urine from other cellular elements. So they can be either lying freely in the urine, or they may be constituents of casts. Especially when there are constituents of a mixed cast, you may find it difficult to distinguish neutrophils from RBCs and lymphocytes and other cellular elements. So here these certain staining techniques like the Prescott body stain or the PP stain, which is very useful. So I'm sure in hematology you must be doing that peroxidase staining, you must be doing similar kind of stain. So what this
Yes, sir. Yes, sir.
I'm sorry for this. Okay, so I was talking about this Prescott body stain. So you can stain the peroxidase containing cells like neutrophils, eosinophils, and monocytes. They will be stained blue, blackish blue. Yes, the granules will be stained blackish blue, and you can easily distinguish them from the other cells. Now, sometimes what happens, you have a clinical conditions where you are suspecting hemosiderin granules in the urine. You have conditions where you have hematuria, or there is breakdown of RBCs where you are expecting to find some hemosiderin. And to detect that hemosiderin, you can actually use a very useful stain which is called as a Berlin blue stain. So if you're doing a good volume microscopy, just ensure that you have the technique at hand to use this. It's a very useful stain where you can stain the hemosiderin granules blue or indigo. Basically, the component here is potassium ferrocyanide, and it stains the hemosiderin granules in a indigo or a bluish fashion. You can see it in this particular case. Now I spoke about eosinophils a while earlier. So a very wonderful stain called the Hansel stain is available. So it's a constituent. The major constituents of this stain are methylene blue and eosin Y. So what it does is it stains the eosinophil granules, the granular components, bright red. So they can easily identify it in a urine. Otherwise, trust me, it's very difficult. Sometimes when you have a mixture of neutrophils, eosinophils, and other cells, it can become very difficult to pinpoint eosinophils amongst that whole cellular infiltrate. So this stain is a very useful stain, and this again is a very highly recommended stain in your armamentarium of urine cytology lab. So a lot of clinical conditions you need to do this, and a lot of time clinicians will ask you to find out how many eosinophils are there and do a serial examination for eosinophils, and this stain is a very useful stain for that. The next component which you need to detect in your microscopic examination are certain glycogen containing cells. So there are certain conditions. I'll come to those conditions in a while. So those glycogen containing cells can be stained by Lugol staining. So potassium iodide, we've all done it we do it in the biochemistry labs. So the Lugol staining technique can detect the glycogen in the cells. So a lot of cases of nephrotic syndrome and other cases where you do get glycogen in the urine, you can detect by this method. These are the main stains. If you want, there are many available, but these are the few main which are not routinely taught in your textbook. I thought I'll just give you a brief note of this. And this is a flow chart which tells you how to do the examination. So you look at cells, the RBCs, the WBCs, the epithelial cells, the whole fat bodies. Then you come to the, so it is a very good practice to form an algorithm for this. You can have your own algorithms. There is no defined algorithm per se. But whenever you do a urine examination, just ensure that you move in a sequence so that you don't, just like you do for other histology or other things, the sequence should be maintained. So you look at cells, you look at casts, then you go to crystals, then you go to organisms, and then you see if there is any other thing apart from these four main categories which you can find out and document. So when you look at cells, you have the RBCs, WBCs, the epithelial cells, the fat bodies. The casts can be cellular or non-cellular. We'll come to that in a while. You look at crystals.
The person you have called is speaking.
So you should be aware that these crystals are normal constituent of urine, or are these crystals abnormal? So normally there are certain crystals which you can normally see in the urine. There are certain crystals which you will never see normally, and they have a very important clinical significance, like cysteine, bilirubin, leucine, isoleucine. And once you're done with these elements, just have a quick look at if there are any organisms. You can often see yeast cells. You can sometimes see trichomina, even microfilaria you may be likely to pick up. And if you are in the correct geographic zone, cystosomy hematomum infection is a relatively common occurrence. And you should also look out for other things like sperms, etc., which may confuse your diagnosis. So this is the basic approach you need to follow for the urinary sediment. Now, there are certain important things which you should know of and often ask not only in your examination, but you also should be aware when you are doing your clinical practice in your lab. So a lot of time you talk about active and inactive urinary sediment. So there are various definitions, but I feel this is the best definition of an active or inactive urinary sediment. So you define active urinary sediment as the one, when you examine a sediment, as having more than 5 RBCs and more than 5 WBCs for high power field, and or cellular cast where none previously existed. So when you do a serial examination and one day you don't find too many casts, but when you do 1 or 2 days down the line, you see a lot of casts. So even that is an active sediment. Similarly, if you look at the flip side of it, inactive urinary sediment is one which has either less than 5 or 5 RBCs and less than 5 or 5 WBCs per HPF, and it usually will not have any cellular casts. Now the next step is going to the cells. So when you talk about cells, you can see erythrocyte, leukocytes, tubular cells, urothelial cells, common cells. You should have an idea of how they look, because they look very different in the urine sediment than you would look at it under your histological sections or maybe other techniques. So you should have an idea of how these cells look after. So when I talk about this lecture, I only talk about the sediment. So the microscopic examination is always a sediment examination, right? So these criteria also are based on the sediment which we are looking at, right? So different kind of cells. So we'll quickly go through the different cells and how you can identify them. And the most important ones being in a urine examination are RBCs. The clinician or the nephrologist or whoever is referring the case to you will always be interested in knowing if there are RBCs, number one, and if there are RBCs, how many, and if there are RBCs, how do they look like? Are they isomorphic or are they dysmorphic? So these are the questions you need to answer in every to every clinician and also document in your right. So when you talk about hematuria, as I told you in the last slide also, it is presence of abnormal numbers of RBCs in the urine sediment, usually more than 5 per eyebrow effect. And these can appear in the urine due to glomerular damage. There are conditions called as glomerulonephritis, inflammation of the glomeruli and other things. And not only this, even trauma, urinary stones, urinary tract infections, the various toxins which can lead to blood in urine, and even physical stress in given clinical conditions can lead to presence of RBCs in the blood. So you need to have a good clinical background when you're examining this urine sediment. And not to forget contamination from vagina and menstruative glands. So you can give a false alarm if you are not aware of the clinical background. Now, normally when you talk about hematuria, the next question to be answered is, especially when you're dealing with nephrologist, is whether that hematuria is a glomerular or non-glomerular. Because once you tell that hematuria is glomerular, a very important decision of doing a biopsy or not doing a kidney biopsy in this patient will be taken. Of course, this is not the only criteria, but this is one of the important criteria. So if you communicate to your clinician that there is a significant number of dysmorphic RBCs or the hematuria appears glomerular in nature, sooner or later that patient will definitely undergo biopsy. Whereas if the RBCs are non-glomerular in origin, there will be a workup to see what are the other causes, non-glomerular causes, and then they will be dealt on one-to-one basis. So it's a very important decision to make. And in this particular decision, using of phase contrast microscopy is a very, very useful tool. So what it does, it gives a very nice contrast to the RBCs, and the dysmorphic features like the abnormal membranes or the protrusions or blebs on the RBCs, they can be very well seen in a phase contrast microscope. Not saying that you always need to have it, but if you have it, use it when you are trying to do examination of hematuria, or else you can just lower your condenser well and try to see if there are how many dysmorphic RBCs are. Now these two images tell you, on the left side, the A section tells you rounded, well-rounded RBCs which are isomorphic. Whereas if you see on the right side, you can see various RBCs which have got a lot of abnormal forms. Some of them have got irregular membranes, some of them have got these protrusions, the one which I am highlighting, just like sometimes you can have two protrusions and then that RBC is called like a dog's ear. So you have two small ears which are protruding from the top. So these are all examples of dysmorphic RBCs, and you need to quantify how many dysmorphic RBCs are there. So this is just a busy slide. These are various isomorphic and dysmorphic RBCs, various type of dysmorphic RBCs. The P23 and the P24 and the P26 are the ones which you commonly see as protrusions on the RBC membrane, right? So once you have done with the RBCs, usually this is what I was talking to. So if you have more than 80% of RBCs as dysmorphic, you should document it. So usually the decision of deciding whether the hematuria is glomerular or non-glomerular is taken on percentage, and 80% is a good cutoff. So more than 80% dysmorphic RBC is a very reliable indicator of a glomerular. So you really cannot have very fixed cutoffs here. It's very difficult to do a controlled study on these specimens because there is a lot of biological variability, but 80% is a good cutoff, right? Now coming to WBCs. So when you have a lot of WBCs in urine, it's in layman term, if you want to call it, it's called as so usually you will not get dysmorphic RBCs more than a cutoff in stones. Most of the RBCs will be isomorphic. So pyuria refers to the presence of abnormal numbers of WBCs that may appear with infection of the UTI, urinary tract. And here it is also important to remember that when you are examining the sediment, the contamination from vagina, especially in presence of vaginal and cervical infections or the urethra, men and women, can contaminate the urine. So you need to be very clear about what you are seeing. So coming to neutrophils. So neutrophils are the ones which you need to identify with great certainty. And you can identify, you can have a rough idea about the size, can compare it with the surrounding RBCs, and they will have a granular appearance in their cytoplasm. Right? So they have a rough diameter of around 10 microns, and will have a granular kind of a cytoplasm surrounding a lobulated nucleus. And you usually report them in terms of number of cells per high power field. So you should always do that. You should make it a habit of reporting whatever cellular elements you see. You should make it a habit of reporting them in numbers seen per high power field. So once you follow a consistent pattern of reporting, it will be helpful for your clinical practice also, right? And you can use special stains that I told you earlier. If you remember which stain to be done for neutrophils, it will be a good thing. You can just capture it and recall. Maybe we'll have a case in the clinical cases sections. Now coming to lymphocytes, so lymphocytes obviously will not have any granules, and they are not large. A good number of lymphocytes usually indicates chronic inflammation. So viral diseases is one very common condition where you will find a lot of lymphocytes. So when you have outbreaks of dengue, or even during COVID times, when you examine urine of patients, you would see a lot of lymphocytes. So viral diseases are one condition where you get increased number of lymphocytes. Now, when you, if you are practicing in a center which also does renal transplants, you will often get urine samples from patients who have undergone transplantation. So there you do a serial examination. There have been studies which had shown that if there is a abrupt or even a gradual appearance of lymphocyturia in the renal, this may be an earlier feature of an cellular rejection. So there are a lot of studies which substantiate this particular thing. Of course, it's a difficult thing to do in practice, but if you are regularly seeing urine of patients who have undergone renal transplantation, just keep in mind that you should always compare the last findings with the present one. And even if in a given sample you see a large number of lymphocytes, you can raise an alarm to the clinician to check if there is impending rejection or even an ongoing rejection. So yes, neutrophils will not appear mononuclear, so they will usually appear lobated, but you can identify them by the granules in the cytoplasm. So lymphocytes will not have granules, neutrophils have granules. Now eosinophils, I have told you earlier, I think a couple of times already, very important when you do a urine examination and do a Hansel stain. And the importance lies either in detecting an allergic response, or when you talk in terms of kidney biopsy, you see a good number of eosinophils when there is an acute interstitial nephritis. So various causes like drugs, innumerable number of, I think almost every drug can cause interstitial nephritis, but more so a lot of antibiotics, methicillin. Then there are conditions like atheromembolic renal disease, which I just told you in the first slide, where the clinician in a post PTCA patient will often do a urine examination for eosinophilia. Then you can also get them in UTIs if there is an allergic UTI, even an allergic prostatitis, and in the given geographic conditions, even urine schistosomiasis or other parasitic infections can give rise to large number of eosinophils. So eosinophils should also be viewed with caution and reported very diligently in a urine examination. Now coming to tubular, so now we have done with those granular thing. Now we go to the epithelial cells. So you often get renal tubular cells in the urine sediments, and it's very important that you identify them and not mix them up with either granulocytes or lymphocytes or other cells. Otherwise you will, if there is a lot of shedding of tubular epithelial cells and you do not identify them as tubular cells and report them as lymphocytes or neutrophils, you may give a wrong impression of pyelonephritis or something else and lead to wrong treatment also. So it is very important to identify the tubular epithelial cells. So these are slightly larger. I told you lymphocytes are usually 10, and these are roughly 13 to 14, 15 microns in diameter. You can gauge it by the surrounding cells. And few tubular cells have a rectangular or polygonal shape, and you often find them when there is an acute tubular injury. You must have heard this if you are reading renal pathology. You will know there is a condition where the tubules, the proximal tubules, get damaged. So the cells from those tubules shed into your urine, and you can see them as renal tubular cells. And remember, a lot of proximal tubule cells have got a lot of mitochondria, a lot of granular material in the cytoplasm. So it is very important that you distinguish these cells from neutrophils and other granular cells, right? And like I just told you, you can get them in, even in an acute allograft rejection, you can get a lot of renal tubular epithelial cells. And if there is a lot of glomerular inflammation or inflammation of the kidney in general, these cells will shed off and appear in the urinary sediment. Now, So, uh, so by the size, so the renal granulocytes will be usually smaller. The tubular epithelial cells will usually be larger, and epithelial cells will usually have a single nucleus. And most of the granulocytes have more than one nucleus, right? So you can, by experience, you will be able to differentiate them by size and the granular and the lobated nuclei often which you see in the granular epithelial cells, right? Now sometimes urothelial cells also appear in urine, and for the same reason you need to identify them so that you won't mix them up with other elements. And even here you can identify the superficial from the deep. So as you must have seen in your histological sections, the deeper urothelial cells are slightly smaller. They can be long, elongated, oblong, whereas the superficial ones are larger, almost 30 microns, and easily identifiable, right? And this is probably one of the most common findings in any urinary sediment examination. And you should be able to identify the superficial squamous cells of the urinary tract. They have abundant cytoplasm, small central nucleus, and if you look at the size, they are the largest cells. If you have a sediment and you see large cells, you can be sure these are epithelial cells. Now they are normally found in smaller numbers, so it is very difficult to have a cutoff per se, because even in minor inflammatory conditions they can increase in numbers. But it's important that you identify them. And then you look at the background and see the more important things around. And usual exfoliation will lead to formation of these appearance of these cells in the urine. But whenever you see a large number, the first thing you do is to, if it's a female patient, you just ensure that it is not a contamination of the urine from the vaginal discharge, right? Now I spoke about lipids earlier. I had shown you one of the stains which you can see, by which you can identify the lipids in urine. And whenever lipids appear in urine, they appear mainly as droplets. And these droplets themselves can be isolated, or they may actually aggregate together and form large structures. That's one part. And secondly, they can also be component, either they may lie outside the cast, or they can also be a component of the cast. So when they are in casts or cells, they can form oval fat bodies, which are nothing but tubular cells or macrophages which are engorged with lipids. And a very useful technique to use in these particular cases is polarized lights. When you use a cross-polarized light, I'll show you the slide in a moment. When you use cross-polarized in a urine sediment, these lipid droplets or oval fat bodies give beautiful Maltese crosses. So these are cross-like structures which are, because of the birefringence, they give Maltese crosses. So you find increased number of lipids in nephrotic syndrome or erythropoiesis, of course, that's logical. But even in patients with polycystic kidney disease or non-glomerular disease, you can get a good number of lipid droplets. So you should be able to identify and report it. And sometimes even without the aforementioned conditions, if there are primary abnormalities of the lipid metabolism per se, for example, Fabry's disease or other cases, you can get a large number of lipid droplets in the urine. So it's very important to identify them. This is how they appear. So if you look at this this is the polarized image of these lipid cast and oval fat body. You can easily identify a beautiful Maltese cross-like appearance. It's very characteristic. Once you see it, you will never forget it in your life. It's really, really dramatic. It's very easily identifiable. So you don't have to use any stain. If you have a polarizer, just rotate it and you will be able to identify these lipid droplets, oval fat bodies or lipid casts, right? Now, apart from this, when you specifically look at casts, this is another very important parameter of microscopic examination. So if you look at cast, or if you want to define cast, these are basically elongated elements who have a basic cylindrical shape, and they can exhibit great variation due to bending, wrinkling, irregular edges, whatever. And sometimes, many times, you have cellular elements which are embedded in this cast. And the basic constituent of all the casts is a TAM protein. So it is it's a glycoprotein which is secreted in abundance by the thick ascending loop of the membrane and early distal convoluted tubules. And if you look at it on a volume to volume basis, 1/3 of total urinary protein is composed of TAM phospholipids. So what it does is it forms the matrix of all casts, and everything you see, all the casts, RBC, WBC, whatever, they are all created on the matrix of these TAM phospholipids. And if you're looking at renal biopsies, also you can identify this TAM phospholipids protein in the distal tubular cast and their Many times it appears normal. Sometimes when it decides that it has to move out of the tubule because of obstruction or something, it can elicit an intense inflammatory response. So if you want to classify casts, you can classify them in either as matrix casts, where you do not have any additional cellular elements. So they are just composed of those hyaline or waxy kind of appearance. And on the other hand, there will be inclusion casts, wherein the matrix of a time household protein, you will get protein, cell debris, fat globules, you can get hemosiderin, and sometimes you can also get casts which are composed predominantly of crystals. So, and apart from this, you can have pigment in the cast, you can have hemoglobin cast, the myoglobin cast, the bilirubin cast. And apart from this, if it is a pure RBC cast, we call it a erythrocyte or RBC cast. Neutrophil cast, where it is predominantly composed of neutrophils or other mononuclear cells, lymphocytes. You can have casts composed predominantly of tubular epithelial cell, but most often you get mixed casts. So when you look at casts, you will find a mixture of various elements, and then you have to take a call on which is the dominant one, which is the most clinically relevant one in that whole clinical context. And if you have a lot of bacterial infections, even bacteria can become component of those casts. So you can have bacterial casts, fungal casts, bacterial casts, whatever. So we'll take them quickly one by one so that you have an idea of how these casts look like. So these hyaline casts, the one which you can see on the right side, is the most frequently observed cast, and it is almost entirely composed of only thymosyl protein. And since it is a very low refractive index, it is not very easily visualized. So the image which you are seeing here is of a phase contrast microscope, and it is very, very difficult to identify these casts in a normal urine sediment. Even if you lower your condenser, these will be very difficult to see. And these are normally seen, but increased numbers can often be found with exercise, when the patient is on diuretics, and even in patients who have heat stroke or heat exposure, you can get a very large number of hyaline casts. It goes well with dehydration and fever. So they are all go hand in hand, these clinical conditions. Now, in certain conditions, these hyaline kind of casts, they become more deeper in appearance, right? So when they are deeper in appearance, they are better visualized even on a routine examination. There, these are called as waxy casts. The basic difference between a hyaline and a waxy cast lies in the better delineation of these waxy casts because of chronic nature of the disease because of which they have been formed in the tubules, right? And a chronic inflammation, chronic degeneration, chronic interstitial nephritis, you will always see a good number of waxy casts. So one good use of these waxy casts is, if you see a large number of waxy casts in urine, you can go back to the clinician and say that this patient probably has got a lot of tubular atrophy and interstitial fibrosis in his kidney. So there's a lot of chronicity. So the chronicity usually correlates well with the number of waxy casts which you can see in the urine, right? Now on this, you can see granular casts. You have fine granules, and when you have granular nephritis, these are the most common casts you see, because they are composed of various either the cell debris or the cytoplasmic content. They just go and stick onto the basic cast and cause formation of granular casts, right? And you can also have WBCs, RBCs, the renal tubular cells, as components of these granular casts. So normally you will see them in association with a lot of glomerular diseases, tubular diseases. As I told you, interstitial diseases. If you're looking at grafts, you will also see a lot of granular casts during an acute allograft rejection. And if you may have heard of a condition called as renal papillary necrosis, it can happen in diabetics, where the entire papilla get necrosed and sloughed off in urine. So you do get a large number of post-granular casts in cases with renal papillary necrosis. Just remember the clinical conditions where you get these casts, and you can go back to the clinician and ask how this patient is doing or what this patient has in the background. I've spoken about the fatty casts, and commonly seen in nephrotic syndrome. You just have to polarize your microscope, and you can see nice Maltese crosses, right? And depending on what crystals are in urine, sometimes these crystals can become incorporated as a part of those waxy casts or hyaline casts and cause crystal casts. So you can have a urate cast, you can have a sulfonamide cast depending on the drug. And what it does is basically negates deposition of crystals in the tubule or collecting duct, right? So because of that, the basic matrix is formed there. The presence of these crystal casts tells you that there is deposition of crystals in that particular segment of the nephron, right? Somebody was asking about RBCs, right, earlier. So these tubular casts can cause hematuria, but it will be isomorphic, right? Now, similarly, this is a very important thing. Please pay attention if you haven't till now. So these are the casts which cause the maximum problem. So you do get a lot of pigment casts, and not only do they cause difficulty in diagnosis, they are the ones which are associated with a lot of clinical relevance. So you should be able to identify myoglobin casts, which appear, as you can see here in the right side, they appear as long, stringy, appearing dark brown colored structures. And often these patients will have an acute renal failure. So myoglobinuria can occur with rhabdomyolysis, conditions which called rhabdomyolysis. It can be drugs, physical exertion, whatever. So you should be able to identify myoglobin casts. Similarly, patients with significant or severe liver dysfunction can also have bilirubin casts. So they appear as golden brown colored pigments. So these are stained by them. You don't have to use any stain to see them. These bilirubin casts will be self-stained and are often seen in obstructive jaundice and acute hepatitis. And wherever you see these, if you look at the biopsy of these cases, you will see nice bilirubin casts in tubules. So we call that bile cast nephropathy. Right? It's the same thing which you see in the urine. And just like whenever RBCs degenerate, they will release hemoglobin, right? So that those casts can form hemoglobin casts. So you can even get an hemoglobin cast in a patient who is having degenerated RBCs. Now, I talked about RBC cast earlier, a lot of inflammatory conditions. We spoke about acute glomerulonephritis, IgA nephropathy, lupus nephritis, pyelonephritis. Even pyelonephritis, you can get a good number of RBC casts. But remember what you have to do, and just recapitulate. You look at an RBC cast, you see how many RBCs are there. Can you identify dysmorphic RBCs even within an RBC cast? So if that is the case, if you can identify the dysmorphic RBCs, it will be a good indicator of a glomerular hematuria. And remember, RBC casts almost always determine glomerular hematuria. So it is very, very unlikely that you will have RBC casts in absence of glomerular hematuria. So that there lies the importance of identifying the RBC casts in a urine sediment examination. Just like RBC casts, you can have WBC casts. And if you're having difficulty in identifying the components, you can do the various stains which I had told you earlier, right? And you do find a good number of WBC casts in infections and even in inflammatory conditions of the kidney. Now, interestingly, if you don't see a lot of renal biopsies, the interesting part about renal biopsies is that normally in other organs we called inflammation usually is composed of neutrophils, right? When you call itis and all those things. But interstitial nephritis is one condition where you don't find neutrophils, you find lymphocytes, right? So a lymphocyte-rich interstitial inflammation is acute interstitial nephritis, and a neutrophil-rich interstitial inflammation is pyelonephritis. So please carefully remember these and try to differentiate these two conditions and get it in your mind especially when you are seeing kidney, right? Kidney is a unique organ. So you can have epithelial casts, nothing great about it, but you should be able to identify them, basically, not to confuse them with any other condition. Now lastly, crystals. So we'll quickly go through the crystals. It is important to identify crystals, and usually these crystals are formed when the urinary salts precipitate, and a lot of factors which are determining this, so like pH, temperature, the concentration of the urine, and these conditions will affect the solubility and lead to precipitation of these urinary crystals, right? And don't be happy if you identify just one. So there are often more than one type of crystal in a urinary sediment. You should have a good look at examination of the urine and try to identify as many types of crystals you can find in urine, because it is possible that a normal constituent may be dominant, for example, oxalate crystals in slight dehydration, but in the background there is a cysteine crystal sitting which you may just miss out, right? So be ensure and remember that you can get several types of crystals simultaneously in a urinary sediment, and they can be found both in acidic and alkaline urine. And some crystals fortunately are bifringent and the polar is light, and you can identify by just rotating the polarizer. The most dramatic one is the uric acid. It gives you a very dramatic multicolor appearance when present, and even calcium oxalate depending on its state of hydration. Okay. So this is uric acid crystal. So these are rhomboid forms. You can also get sheaves and other things, and they are like lozenges. You can see a very nice structure to them. And what it does is, what the importance of finding uric acid crystals is, they usually reflect an increase in nucleoprotein turnover. You know that, right? So in patients who are undergoing chemotherapy for leukemia and other high metabolic states, you will find a lot of uric acid crystals in there. And this can also be an indirect indicator of a uric acid stone which is lodged in the ureter. So you can have uric acid crystals being shed from that particular stone. So it is very, very important. Many of these patients actually have a gout or a hyperuricemic condition. Okay, so just ensure to identify uric acid well. Now this is oxalate crystals are the most common crystals you will see in urine sediment, and you will see two types. So the first part is the classical which you have been taught in your I think 11th, 12th also that's tell. Those are the envelope shaped crystals. You know? So those crystals are basically the bihydrated forms of calcium oxalate. Okay, and these are the ones which are brightly birefringent. The other ones which are the biconcave or the biconvex are usually the monohydrate forms, and these do not polarize as well. So it's a bihydrated or the envelope form of calcium oxalate which gives a nice birefringence, whereas the monohydrate one, it is slightly less birefringent and has a different dumbbell kind of shape. Now the importance of calcium oxalate crystals, while they can be normally, occasional crystals can normally be seen, the problem is when there are too many, they can cause a lot of tubular injury. So they can cause injury and lead to a lot of problems with the tubular epithelium and can cause damage to the kidney. And pathologically or as a metabolic disease, you can be seen in primary hyperoxaluria, which is a very devastating condition. The kids usually affect, it can be familial. The kids can have primary hyperoxaluria at very early stage in their life. And unfortunate part is, if it is a metabolic disturbance, if you do only kidney transplantation, it will come back. So you have to do a combined liver and kidney transplantation for these patients. Okay, and you can also see them in ethylene glycol toxicity, a lot of off prescription drugs, a lot of traditional medications. They can lead to formation of oxalate crystals. One important drug, if somebody is from South India, they will realize. So there is a drug called, there is a fruit called as Avoria carambola. I think it's called the star fruit or something. So ingestion of that star fruit induces a terrible hyperoxaluria and leads to acute kidney injury. So that is a very important thing to identify, right? Not only this, if you have a patient with small bowel resection or Crohn's disease, you can get increased amounts of oxalate crystals, right? So good number of clinical conditions which you need to remember and exclude when you see calcium crystals. These are the most common ones, remember. And these are the rarer ones, but even though rare, they've got high diagnostic significance because they are never found in normal urine. So cystine you will never find in normal urine, and it's got a very characteristic hexagonal birefringent plate appearance. Once you see it, you will never forget it. So cystine crystal is a hexagonal birefringent plate with irregular sides, and they can often get heaped upon one another. So you can get a 3D kind of a structure of cystine stones, and importantly, they are only most of the times found in acidic urine. And they can also be an indicator of cystinuria, which is again can be a hereditary disease, and often be a part of cystine calculi, right? So cystine is an important crystal to remember. And now, and apart from this, you should remember that almost every drug which we give to the patient can lead to formation of crystals. But there are certain drugs which have got a typical appearance. So the one which I have shown you in this picture are crystals of sulfadizine. So sulfadizine is a commonly given drug where you can get these broom shaped, if you want to call it, needle shaped crystals arranged in form of brooms as a form of sulfadizine therapy or treatment. And other drugs like antivirals like indinavir, cyclovir, a lot of barbiturates, vasodilators, even vitamin C. Vitamin C will also induce a lot of oxalate crystals. Amoxicillin antibiotics will give formation of crystals in the urine. So whenever you see a lot of crystals, these are the conditions which you need to. Last but not the least, I think this is the last one. You can get cholesterol crystals. Very difficult to identify, but if you can lower your condenser and use a polarizer, you can identify them as thin plates. They are very thin, so they're not as thick as cystine, and they have sharp edges and corners. So it's really easy to identify this. Right? This is just to summarize, give you an overview. can have uric acid, oxalate. I didn't intently take up a lot of the uncommon ones, but the common ones mostly I have covered, right? And just to take this into account, sometimes you will see a urine which has a lot of these worm-like brown structures. So these are actually ammonium biurate crystals. So you should remember that these are not contamination or anything. These are ammonium biurate crystals, right? So we've done with most part of it. So the remaining thing is you should not ignore the bacteria. The bacteria they can arise as contamination. If you hold the urine for too long, they can arise they can proliferate there, although they may not be pathogenic per se in the patient. But nevertheless, you should be able to identify and note their presence, abundance, presence, and give a note, right? So if you are examining a urine which has been kept for a lot of time, just make a note there that I'm examining a urine which has been kept, and this may reflect a contamination or an overgrowth, but don't ignore it, right? Always document the bacteria. They can be rods, cocci, can even be contamination, as I just told you. And in patients with acute pyelonephritis, you can even get bacterial casts. So you have a lot of bacteria in the kidney which are causing inflammation, and they can get incorporated into those diamorphal protein cast matrix and cause bacterial casts, right? So just like that, fungi, I'm sure people who examine urine will often find these candida. Candida is the most common fungal organism seen. Mostly you see these budding yeast forms. So don't ignore them. They can also be contaminants and overgrowth, but you should always be able to correlate them with the clinical condition and your culture. So these are rarer ones, schistosomia hematobium. So if you go and practice in the Middle East, you will get a lot of these cases. So it's a very common endemic infection in the Middle East. A lot of schistosomia hematobium eggs appear in the urine, and they've got a typical characteristic spine-like appearance at one of the edges, right? So that's all about the urine examination background. I hope you have covered most of the part of it. But what I would, as a takeaway, what I would tell you, do not treat urine examination as a routine test. So if you do it very diligently and you create a structure around your test, you can actually develop it into a specialty. It's a very, very important test. And in these days of NGS and other